in the last video we have discussed about BLS, and now we will talk about ACLS, Advanced Cardiac Life Support. What it is and how we will differentiate between the BLS and ACLS. Okay, in case of BLS, we are using AED, automated external defibrillator, and here we will use only defibrillator. What is the difference? It is machine made. The machine is starting the rhythm, and he is saying, the doctor or the person, whether it is shockable or not shockable. But in case of ACLS, the person or doctor should be decided that it is you have to give shock or not. It is dependent on you yourself. Okay, it is not machine dependent. And here you will do ECG, and you will do the differential diagnosis. Okay, and like I have said in the previous video, that whether it is pulseless electrical activity or ventricular fibrillation or ventricular tachycardia or asystole. Okay, you have to differentiate between this, and you have to also consider about some reversible condition, and then do like this. Okay, now see what are some difference between cardioversion and defibrillation. Now cardioversion and defibrillation, we are using these terms interchangeably, but it is quite different. In case of cardioversion, we are giving synchronized DC shock. What is it? You have to give the DC shock at the peak of R wave. It is a P wave, QRST. Here you will give the DC shock at the peak of R wave. You will give it in case of synchronized DC shock is given in case of paroxysmal supraventricular tachycardia, AF, atrial fibrillation or atrial flutter. Okay, then you should give cardioversion, and it is in case of defibrillation, it is non-synchronized. And what is it? You can give it to the in any phase of ECG, as you can differentiate. Like here the ECG is distinct, but here you have some different patterns of ECG where you may not find the whether it is when it will be R wave or P wave, QRS wave, Q wave. Okay, you can differentiate. So then you have to give the non-synchronized DC shock. Okay, now see, shockable rhythm and non-shockable rhythm. Shockable, I am representing it as S, and non-shockable NS. Okay, not normal saline. Okay, now non-shockable rhythm, shockable rhythm. Shockable rhythm is good. You are connected the patient with ECG machine. You have seen there is ventricular fibrillation like this, ventricular fibrillatory wave, VF. You will directly go for DC shock. Okay, or you are seeing this type of pattern. It is ventricular tachycardia. Then you all also can give the shock. Okay, now here you see in non-shockable rhythm, it may be asystole or flat line. Not a flat line means always dead. You have to see whether the ECG lead is well placed, or the voltage is good, or there may be some internal condition of the patient. Asystole it is, or it may be pulseless electrical activity. The ECG pattern is good, but you can't find any pulse of the patient. PEA. The most common cause of PEA is hypothermia. You may have seen the film Titanic. The hero of the film, Jack, was drowned in the drowned in the sea, and at last he was confused, disoriented. Why? He was probably going through pulseless electrical activity. So hypothermia is one of the cause of pulseless electrical activity. Okay, now I have said that in case of shockable rhythm you will directly go for DC shock, and in case of non-shockable rhythm, in pulseless electrical activity, you have to go for the reversible change. But in case of asystole, you may try the non-shockable rhythm to convert in shockable rhythm. How? See, adrenaline is available. You have to push adrenaline IV. You are giving IV adrenaline. Okay. IV adrenaline. Sorry, give me a minute. Okay, thank you. By you are pushing adrenaline, then it can be converted into the shockable rhythm or into ventricular fibrillation. Then you can give DC shock to the patient. So other patient. So I am simplifying it. Okay, let's see. You have given you have given you have given the patient BLS already. Now the patient is in hospital. Now you connected the patient with ECG machine, and you have seen that it is shockable rhythm, and give DC shock, non-synchronous DC shock. You have to continue CPR. Okay, CPR, and if if the pulse is not coming, then you can give IV epinephrine to the patient or adrenaline. 1:10,000 IV always, or intraosseous, not intracardiac. It is not in the guideline now. Okay, it was old school thought, but it is not used now. You can repeat this cycle CPR and IV adrenaline until the patient's pulse is recordable, or you can feel. DC shock, CPR and IV adrenaline we will give to the patient by 3 to 5 minutes interval, and always check for the pulse of the patient. And at last you can give IV amiodarone to the patient. Amiodarone, in your medical school it can be available by as cardarone. Okay, cardarone. And at first dose 300 milligram, then subsequently you can give it to 150 milligram IV. Okay, but now see, if it is non-shockable, what to do? Non-shockable, you have to continue with CPR, and you will give IV adrenaline to convert the non-shockable rhythm to shockable rhythm. If it is converted, then you can continue with DC shock. Okay, otherwise you have to continue with CPR or adrenaline. Okay, this is the Acls. And now see some reversible cause. If there is some reversible cause, you have to treat the reversible cause. Okay, now you can remember 5H and 5T. What is the 5H? Hypovolemia. The patient has undergone surgery. There was a lot of bleeding. You have to give the patient some fluid. You may have give to some hemocell, like it is a type of colloid, and you maybe have some given some crystalloid rising galactate in a sorry. You may have give blood transfusion to the patient. And next stage is hypoxia. Hypoxia. You have to give patient oxygen. Okay. Now hydrogen ion or acidosis. There may be metabolic or respiratory acidosis. You have to give sodium bicarbonate. Okay, acidosis is very much dangerous for the patient's heart and also brain. Okay, now hypo or hyperkalemia, both are dangerous. Both are dangerous. Hypo or hyperkalemia, both are dangerous. Hypokalemia can uh, hypokalemia can lead to torsades de pointis and diaphragmatic paralysis, which is the most common cause of death in this patient. Okay, and in case of hyperkalemia, calcium excites heart and potassium depresses, so there will be diastolic failure, diastolic heart failure. Okay, in case of hyperkalemia, diastolic heart failure may present. Okay, you have to deal with this hyperkalemia. In case of hypokalemia, you have to give injection KCl, or in case of hyperkalemia, you can give calcium gluconate or insulin dextrose. Okay, or potassium binders as a hypothermia. Hypothermia, I have said it is one of the cause. Like I have given example of Jack in Titanic movie. Okay, hypothermia, you should OD-warm the patient with some blanket, or some you may give the patient some fluid. 5H is over. Now 5T. What is the 5T? First, some toxins. Okay, some drug overdose may do this, like cocaine poisoning. Cocaine poisoning. Now in case of tamponade, what is tamponade? When excess blood or any fluid is surrounded by the surround the heart, then the heart can't pump properly. Okay, cardiac tamponade. There may be tension pneumothorax. One patient, one soldier is in, or any patient, or any person in road shot by a bullet. Then the bullet injures his lung. There may be some tension pneumothorax. The situation is quite similar to cardiac tamponade. Okay. Now thrombosis. Thrombosis may be two types. It may be MI thrombus or pulmonary embolism. In case of pulmonary embolism, S1Q3T3 pattern is observed, and in case of MI, ST elevation MI is more dangerous, and you have to concern it more. You have to keep streptokinase, S mona, the mnemonic, morphine, uh, morphine, oxygen, nitrate, and aspirin. And in case of ST elevation MI, you have to keep streptokinase, S mona. Okay, okay. And in case of pulmonary embolism, it is a treated condition. S1Q3 T3 pattern is observed. You have to deal with this reversible cause also. Okay, now we have done with ACLS. Thank you.